Welcome everyone again to our session with Dr. Ashfaq Chauhan. Ash will be presenting to us on understanding and improving patient safety for culturally and linguistically diverse patients accessing cancer care. I'd like to first take a moment to acknowledge that we are all sitting on Indigenous land wherever we may be, and pay respect to elders' knowledge and the care of the lands on which we walk, past, present, and hope for those who will be caring for this land into the future. Ash, I hand over to you.
Thanks, Emily, and thank you everyone for joining in here today, and welcome to you all. So as Emily said, I will be presenting this particular presentation on the topic of co-design, which was conducted as part of my doctoral program of work, and I'll present this co-design with one another study that I did as part of my PhD. Before we start, I would like to also acknowledge the traditional custodians of the land on which we are meeting today, and any Aboriginal or Torres Strait Islander people who are here, and pay my respects to elders past and present. So just to give a brief overview of the session today, so I will briefly describe the research approach that I used. And as I mentioned earlier, that I will, in addition to the co-design, I will also speak in a little bit more detail about a medical record review study that I conducted as part of my doctoral program of work and beyond that. And this was an important study because it, to our knowledge, is the first study in Australia that is highlighting patient safety events for people from culturally, linguistically diverse backgrounds in cancer care in Australia. Following this, I will talk about the co-design of making it meaningful medication management tool, and this is the paper that led to this webinar series or webinar inclusion. And then typos there, reflection on consumer co-facilitation. I think this is something that I will be very keen to share some of the experiences of use of involving a consumer co-facilitator in co-design approach, followed by questions. So my PhD was conducted, addressed 4 objectives, and it was around enhancing patient safety for patients from CALD backgrounds in cancer services. It was part of a wider project called Can Engage Project, and Can Engage Project was led by Professor Emma Harrison and was funded by NHMRC Ideas and Cancer Australia grant. I did series of studies that describes in this chart over here, and ultimately used experience-based co-design approach to develop a patient safety intervention. So the approach kind of reflects the double diamond approach in terms of in the first phase, we explored what were the safety issues through a range of contextual and experiential data. And then we used co-designed through a series of 3 co-design workshops to produce or co-develop a solution with consumers and clinicians. So we know that there are disparities in health outcomes and services for people from culturally and linguistically diverse backgrounds. They're less likely to have health insurance and access to care or treatments. They have a higher incidence of medication safety problems. They have lower screening rates, especially in cancer care setting. They also have late diagnosis, and which impacts on their subsequent treatment, and have disparity in health outcomes in relation to mortality as well. So when we started these studies, as part of my program of work, I undertook a literature review of 45 studies, and this was published in 2022 to understand what are the common or what are the safety events experienced by patients who are from CALD backgrounds. And through the systematic review, the medication-related safety events or medication safety events were most commonly identified as safety events. And in the context of, they occur in the context of the language barriers. So people who did not have, where interpreters were not used, or so, sorry, where trained interpreters were not used, they were more likely to have errors in their medication communications. And the dosing errors were twice as likely among low English proficiency patients when compared to those who were English proficient. There were also disparities noted in healthcare-associated infections, where people who were from culturally linguistically diverse backgrounds had higher incidence of healthcare-associated infections observed in the studies. People also, in some of the previous work that we took, people from CALD backgrounds also experienced that they felt unsafe. So this experience was very kind of key as well in terms of understanding consumers' perspective on patient safety. However, in this series of included studies that were included in this review, there was absence of evidence from cancer services. Most of these studies were used patient administrative data sets. So there were large administrative data sets across from health services or health system level, especially in the from the data that came from United States. But there was lack of evidence around what was the state of patient safety for patients from culturally linguistically diverse backgrounds in cancer services. So to fill in some of the factors that we observed from the systematic review and the other work that we have done, which contributes to inequity, and I think most of the people over here would not be new to this, were around at system level and service level, where there is a lack of access and lack of cultural competence or culturally sensitive or culturally appropriate care delivery. Uh, Along with that, the intra-ethnic group variations and the particular CALD characteristics such as language proficiency, time spent in the host or the country of residence, acculturation, religion, faith, especially in the context of cancer as well, around cultural beliefs around what cancer is, etc. This all have influence on how health outcomes are realized for people from CALD backgrounds and can contribute to inequities in cancer care. So to address the evidence gap that we identified in the systematic review around what is the state of patient safety for people from CALD backgrounds in cancer care, we undertook a retrospective medical record review study. And the main aim was to determine the frequency and nature of safety events experienced by people from CALD backgrounds in Australia, and also to examine if there is any association between occurrence of patient safety events and sociocultural factors identifiable from administrative data sets. So as I said, it was a two-stage retrospective medical record review study, and we used a adapted oncology trigger tool to assist us with this medical record review. This trigger tool was developed by cancer researchers in the US, and we adapted it with help of medical oncologists here in Australia for it to be reflective of the Australian indicators, for example, the drug names and as such. So this study was conducted across 4 cancer services, 2 in New South Wales and 2 in Victoria, and they were all based in the metropolitan region. And these 4 services provided or cared for a substantial population of culturally and linguistically diverse people. We reviewed a total of 628 medical records across the 4 services, and eligible records for review were those of for the patients were belong to 18 years or over, or were from CALD backgrounds, and when they had the first episode of care in 2018 to 2000 from 1st of January 2018 to 31st of December 2018, and we followed them for a period of 1 year from their first episode of care. And they need to have a diagnosis of cancer, any type of the diagnosis of cancer. For from CALD backgrounds, we used 4 indicators. So country of birth, preferred language, language spoken at home, and interpreter required. If any of this indicator was present, for example, if the country of birth was outside of Australia or interpreter required was yes, they were considered eligible for inclusion as a for review. In the preparative phase, as I said, the two data collection instruments were developed, so oncology trigger tool, and we also developed a data extraction tools to collect standardized data across from the 4 services. We reviewed outpatient and inpatient electronic medical record reviews of the patients, and also reviewed the correspondence notes which were scanned or uploaded or available on the EMR system. A project team was formed at the start, and there was a research assistant appointed at each of these 4 services, and training was provided, uh, uh, and a process was established for each service of how to collect the data. And the medical records were identified with help of the health information services and the site-specific cancer clinicians from each site. So we did a preliminary data extraction of the 15 records at one cancer service to establish the process. And then from then on, we collected data in 2 stages. So in stage 1, demographic data of each patient was collected on the data extraction tool. So I've showed on the right-hand side the data extraction tools that we used for the purpose of this study. So one clinician researcher and one nurse researcher, they collected data from each site as part of the stage 1. And then in stage 2, this data was reviewed by the medical oncologist to determine that the safety events that were collected as part of stage 1 they were confirmed as safety events by the oncologist. And also within the stage 2, the type of safety events were then confirmed by the research team or safety experts, patient safety experts who were part of our research team. We used the World Health Organization International Classification of Patient Safety to classify the type of safety events. So you can see on the right-hand side again, the type of safety events that we classified safety events into. And the quantitative analysis was conducted using SPSS software. So what were we found? So as I said, there were 628 records reviewed. 150 records were reviewed at 2 sites in New South Wales, so 300 total records in New South Wales. And then in Victoria, at one site, we had 100 records, and at the other side, we had 228 records reviewed. In both the sites in Victoria, the data extraction was completed remotely because of COVID. It was interesting. The study took quite some time because it was conducted at the time of the COVID, and I think the study lasted for over 2 years period because of the continuous COVID restrictions. Demographic data indicated large variations observed across the 4 services. So overall, 53% of the medical records belong to men when compared to women. For example, the median age was 69. Patients from Southern European regions, so Greek, Italy, constituted 213 out of 628 medical records, 34%. And when we looked at the overall country of birth from 628 records, there were over 60 countries identified in total. And this partly led to the decision to then classify country of birth into broader regional categories rather than each individual country of birth. Similarly, when we recorded the preferred language, or when we extracted data on preferred language, there were over, I think, 40 plus preferred languages, or almost 60 preferred languages documented in the medical records. And so we then, for the purpose of data analysis, we grouped them into English or non-English. So 55% of the medical records, or 346, had recorded English as the preferred language. And 70%, or 440 medical records, had indicated the interpreter was not required. Language spoken at home indicator was not routinely recorded in the administrative field on the MR systems. And this was one of the implications, I think, for our study in the context that we would have missed a large proportion of people, well, not large proportion, but we would have missed people who speak language other than English at home, but their preferred language is English for communication purposes. So that group or cohort of patients were not identified through this record review. And there are also implications for future studies in the sense that because this data is not collected, there is a very real chance that their health outcomes are not routine are not collected. Most of the patients have a type of cancer which was in the group of GI cancer types. And 35% or 220 patient records had indicated that they had combination of surgery, radio, or chemo as a treatment. So what were the frequency and nature of patient safety events in these 628 records? So of the 628 records, 212 or 33.76% record had one or more safety event recorded. So that is to say that 1 in 3 patient or medical record review that we reviewed had at least one safety event recorded. The distribution across the 4 sites I have described below. So site T at the service T, the rate was 1 in 4, but when we looked at the overall, it was 1 in 3, and the rest of the sites had very similar 1 in 3 if patient records that had any safety event. So of the 212 records, 91 records had more than one safety event recorded. And overall, there were 410 safety events recorded from 212 records out of 628. So service C has most of the safety event recorded, but it's also corresponding to the 228 records that we reviewed over there. One record, so from the range, I think there was one patient record that had recorded 13 safety events in a period of 1 year follow-up from the date of their first episode of care. So distribution of safety events. So most safety events, 60% occurred in men. They mostly occurred in the age in the patient records that the age range was documented to be from 61 to 75 years. 52%. So the preferred language was not much of a difference in between when the safety events happened or not. 66% had recorded interpreter not required when in relation to safety events. And when we examined the association between the occurrence of safety event to the sociocultural administrative data, so language spoken at home, preferred language, and interpreter required. So preferred language spoken at home, because there was no data, was not considered in the analysis. So we did the association test for 2 indicators, preferred language and interpreter required. And the chi-square test indicated trend between occurrence of safety events and when the interpreter required was to requirement documentation. So when it was documented that interpreter was not required, there was a trend towards occurrence of safety events in those patient records. So out of 410 safety events, medication or IV fluids related safety events were the most common patient safety events identified, and they were common across both inpatient and outpatient setting. So I'll give you the example of the medication safety events was that the patient in their outpatient setting were not taking the correct doses of a medication, but or that when they were admitted in the hospital, they were taking the medications that they brought from home, which they were not supposed to take. So these were some of the examples of medication safety events. Most safety occur in inpatient setting, and this is largely because I think the documentation of safety of these events influenced this rate. And 70% or most safety events occurred when interpreter not required was documented as administrative data. Now, following this study, we also conducted some focus group with interviews with healthcare staff and participants or consumers from CALD backgrounds in relation to their experiences of engagement in their care and how that influenced patient safety. And we observed that there are differences, or there is lack of shared understanding between clinicians and healthcare staff that often contributes to safety events. So the example that I mentioned earlier about that the patient took medications they were not supposed to take while they were inpatient, or they were taking medications at home in a wrong dose. But in the like when I was doing the record review, and then I observed the notes that when the patient was given a dosage box and when the medications were arranged in a dosage box by the doctor, it improved patient's not compliance, but improved medication safety. So there were certain things around communication and particularly around creating shared understanding of care processes and medication instructions that was identified as a key issue that could enhance medication safety or patient safety for people from CALD backgrounds in cancer care. And creating solutions that are targeted and appropriate can enhance this. So going back to this diagram, which are on the right-hand side, the phase 1 and phase 2. So that was phase 1 describing the safety issues through a range of contextual and experiential studies. And so in phase 2, as we used the co-design approach to develop a safety intervention to improve patient safety for people from CALD backgrounds. So in this part of the presentation, I'll describe the process of the adapted experience-based co-design that we use and development of a making it meaningful instrument that came out as a output of this co-design process to enhance medication safety in outpatient setting. So first, adapted experience-based co-design, what it is. So experience-based co-design is a formal established approach developed by people in the UK. So Point of Care Foundations and the King's College, I think they developed the EBCD approach or experience-based co-design approach, which has a series of 7 steps. But we adapted an approach to suit our needs in the context of that, recognizing that people from CALD backgrounds have additional needs that needs to be addressed for creating equal opportunities for their participation in co-design. So we implemented 2 adaptations to the BCD approach. The first one was involving a consumer co-facilitator in the co-design workshops and attending language, financial, technical, and other logistical requirements of the participants or the group members to participate in the co-design workshops. So we recruited consumer co-facilitators, and these were the consumers who had lived experience of cancer. So they were either cancer patients or were carer for a person with cancer. And we provided them with 1-day training, and that training was around the issues of patient safety in cancer care and what is co-design. During the workshops, we established the process of involving consumer co-facilitators so that we had regular meetings with them. And I will describe the impact of this in the later slides, or experiences of this in the later slides. And we also created clear roles of a clear description of the roles. What is the role of consumer co-facilitators in the co-design process through co-design guide and terms of reference that we developed as part of this adapted experience-based co-design. It was also important that group members who are from culturally linguistically diverse backgrounds, their needs, financial, technical, language, and other logistical requirements are met to create equal opportunities for participation so that they can attend the workshops or they can attend the workshops online or in person. To attend to the language needs, we incorporate bilingual field workers and researchers within our field, within our co-design workshop. We established a process whereby we made contact with each of the group member who were part of the co-design before we started the workshops to identify what were their additional needs. So, for example, do they need assistance with Zoom, or do they need assistance setting up anything else that would assist? Because these workshops were conducted at the time of COVID as well. Most participants did attend in person, but there were a couple of members who participated online. So we identified those needs and addressed those needs. We also remunerated participants for their contribution in the co-design, as per the guidance provided by Health Consumer New South Wales. And to further facilitate their involvement, we also arranged for their transport, etc. And we also asked consumer members to bring their carers if that would facilitate their coming to the co-design workshop where the workshops happened. So there were a range of processes in place that we undertook before the co-design and during the co-designs to facilitate participation. So this is just a brief overview of how the workshop was, 3 workshops were conducted. So we had a preparatory phase that I briefly touched on earlier about what we did in identifying the needs, etc. We had an introductory meeting with all the members so that in the work people knew each other before we go on to the workshops. And after that meeting, we developed terms of reference of how the workshops would be conducted and a co-facilitator guide and a meeting schedule. We then provided all the information to all the members, so they have this information well ahead before of the time for their preparation, etc. And we also remunerated participants for the preparatory work they did. We then conducted, in between the workshops, we also conducted the co-facilitators who were involved. They conducted in-between workshop meeting to identify their roles, what they are going to lead, and how to conduct the workshops. And we also made contact with participants in between the workshops to get their feedback that they were not able to provide during the workshops. And we also, in between the workshops, it also gave us time to go back to the theory and integrate theory into any of the outcomes so that so that the interventions or the strategies that we discussed in the workshops were informed by the theory. We had very distinct aim for all 3 workshops. The workshop 1 was focused on identifying the issue, or what is the problem, what is the one problem that people would like to address. In workshop 2, we brainstormed solutions in relation to the issue identified in workshop 1. And in workshop 3, we integrated the solution, how the solution would look like in the current process, what it will look like, and adapted the current process or develop a new process. So these were the 3 distinct aim of the workshops. And then after that, the outcome was developed. And then after the prototype was developed, it went through various rounds of feedback from consumers until the final prototype was developed. So in the first workshop, as I said, the main question was, what are the issues or that people would like to focus on? So based on the phase 1 data, which included medical record review and the interviews with the patients, consumers, and healthcare staff, these were the range of issues. You can see in the diagram there with the arrow mark. These were the range of issues identified through the phase 1 contextual and experiential data collection. And we took this to the participants, to the group members in the first workshop. And we discussed 2 main things in the first workshop: what are the priorities and what are the solutions which are feasible to address. So I think feasibility is very important to consider when we are co-designing. Otherwise, the solution developed may not eventuate into translation or informing the clinical practice. So feasibility was one of the key important questions that we asked participants, group members, to consider as well in terms of choosing or deciding on their priority issue to consider. So at the end of the first workshop, there was a shared agreement on the issue to address contacting health practitioners in between appointments for medication-related information. So what participants, group members, both consumers and healthcare staff verbalized that, especially in the outpatient setting, when people from CALD backgrounds are at home and they're on medications, there is an often delay in terms of recognizing the side effects of the medications or cancer medications until they become very severe that they have to call an ambulance and then admitted to the hospital. And consumers also said that often they felt that they could not call their treating doctor because they felt like they are overburdening the medical practitioner or the oncologist uh, to ring them all the time with the complaints. So this was the key things identified in the first workshop to address. In the second workshop, then in between the two workshops, we went and searched literature on what are the things out there that we can take to the second workshop. So in the second workshop, we brainstormed current strategies and focused on three elements. So the three elements were accessibility of the information, how accessible it is, how effectively it communicate the issue, and how does that information facilitate interaction. So the outcome of the second workshop was shared agreement to develop a tool that facilitate effective understanding and communication about medication side effects and who to contact. We went back again after that. We searched the literature again to see what are current tools, and also we asked the health service staff from the cancer service with whom this tool was developed to see what is out there currently that can be adapted to suit our needs. And in the third workshop, we took this and then we developed the Making It Meaningful prototype instrument based on what has been currently used by the cancer service. So this image is the wonderful co-design team who developed this Making It Meaningful instrument, which is there here on the left-hand side, as you can see. So this was a two-page instrument, and we did this co-design workshops with Mandarin-speaking consumers. So this tool was then developed in two languages, English and in simplified Chinese for people to use. The publication, Making It Meaningful, is available through Patient Experience Journal. So this tool is a two-page instrument. And as you can see on the left-hand side of the tool on the first page, it provides a pictorial representation and in very brief, what are the most common side effects people may experience when they are going through their cancer care and treatment. And then on the second page, there were very clear instructions what to do when they experience something and who is the contact person to contact when they experience certain things. So this addressed the two key questions that had been identified throughout the three workshops, and it has resulted in the development of the tool. One of the part which was also integrated in the tool is this notes section. And it was important from both healthcare service staff and consumers' perspective that they wanted something to scribble upon, draw things, write their own kind of information, what they should remember, etc. So this tool incorporated that as well, based on the feedback or the needs of the consumers or priorities of the consumers in that sense. So this is the outcome, the Making It Meaningful tool. What's happening currently that we are going to trial this tool at one hospital. We are in the process of getting governance approval and hopefully try this tool with Mandarin and English speaking population as well to see if there is any change in the knowledge and self-efficacy of the patients in relation to their medication management at home. So this will be the two parameters we'll be testing in this pilot study. I also wanted to talk briefly, just a couple more slides in relation to employing co-facilitation. So I mentioned earlier that consumer co-facilitators, we employed consumer co-facilitators as a mechanism to address three things or two things: to balance power and balance priorities in the co-design approach. Oftentimes, when co-design happens, consumers, because of the power difference between the healthcare staff, consumers, and researchers who often do co-facilitate, there may be difficulties, or the outcomes may not be what consumer wanted or consumer may want. Their priorities may not be realized as effectively as it should be. So we use this approach where we integrated consumer co-facilitator along with research co-facilitator in co-design workshops. So based on since the development of the BIM tool, we have conducted 2 other co-design workshops as part of the Can Engage project at 3 different services and developed 3 different interventions. So these are the reflections based on working with consumers across consumer co-facilitators across 3 different co-design groups. So we identified that there are 3 approaches to consumer involvement as a co-facilitator in the co-design. So approach 1 is when there is a planning facilitation approach where consumers and research co-facilitator come together from the start and plan everything together, and they execute everything as a pair. So from planning the workshops, planning the materials, to conducting the workshops, everything as a pair. Approach 2 is that we're planning facilitation approach, where consumers and research co-facilitators come together and they plan the workshops together. But when in terms of delivering the workshop, the researcher may lead the workshop and the consumer may support that. And the third approach was planning the workshop's content together and then taking turns to facilitate the sessions or facilitate what consumer felt more comfortable facilitating. So when we started our co-design approach, we started with approach 1, where we planned the workshop content, the materials together. But towards it was more of a interchangeable approach in between approach 1 and approach 3. What we found that consumer co-facilitators felt more comfortable on leading some sections of the workshops rather than leading facilitation as a pair for each section. So before we went into the workshops, we had a pre-workshops meeting between consumers and between consumer co-facilitator and research co-facilitators. And in those meetings, we negotiated the roles in terms of what consumer co-facilitator would like to lead. And based on that, the research co-facilitator then led the other aspects of the workshops. And we found that helpful in the way that consumers co-facilitator felt more empowered. They also felt more prepared during the workshop. And then for the remaining part of the workshops, they were able to engage the consumer members within the group to bring out their perspectives and experiences to contribute to the co-design. One of the last slides I want to share was about the 10 practical tips for co-facilitation in co-design. So very important things, because when research co-facilitators and consumer co-facilitators working together, there needs to be some kind of processes in place, understanding in place how they will work together. Otherwise, there will be a power imbalance between the two from that stage as well, which will then have subsequent impact on the co-design as well. So first thing is relationship establishment. So acknowledging the experience and skills and how it may impact work together. So acknowledging the experiences of health-seeking consumers, acknowledging their experience as a consumer, acknowledging the experience of a researcher, their expertise, and creating shared understanding of how this relationship will work. And this came through about discussion, meetings during the workshops, meetings in between the workshops when we're planning for the workshops, etc. Role definition and distinction. So there needs to be clear definition of the roles in place, and also how this will look like and what is the level of flexibility within these roles. So developing a terms of reference to refer to in relation to the roles defined, and also creating a living document that consumers can refer to in relation to the role definition and distinction will enhance co-facilitation in co-design. Setting expectations, so determining the expectation at the outset, and also determining what level of contribution consumers would like to contribute to then integrate that in the co-design process and co-facilitation process. Establishing the mechanisms in the process for debriefing after workshops and being open so that there is a sense of I think openness, and also that this is a learning environment for the researchers as well as consumer co-facilitators. Communication signals. So how we will communicate during the workshop. So we often used like single post-it notes in our workshops if we need to convey something about the session in terms of some reflection, or like, for example, oh, we should ask these questions, or how about this particular approach can we focus on this, etc. So determining communication signals for in the co-design workshops, how in between the co-facilitators could enhance co-facilitation. Practicing the sessions, so conduct practice sessions during pre-meeting. So as I said, we established the process where before each workshops, we conducted meetings before the workshop as well between research and consumer co-facilitators, and that provided a mechanism to run a practice session to go through the run sheet, how the session would look like, and then to identify if any issues and improve on them. Support and respect before, during, and after co-facilitation. So you'd agrees mechanism to identify areas of concern. So, for example, we had our project lead as a person appointed as a person to raise any concerns. Check in before and during the session. So before each workshops, we met half an hour early to check in everything was there, to check in how the group will run. And in between the workshops, during the break, we will check in again with each other, how the groups are doing, and if there is any additional support needed in relation to what needs to be covered subsequently. Sharing tasks between meetings, and this enhanced equity in the roles. So for example, we had tasks around, we will search this particular intervention, so we will divide that between us, so there is sharing roles to enhance equity, so that each facilitator felt like they are contributing equally to the co-design process. Sharing reflections immediately and after the workshop, and after some time, to identify opportunities for improvement and collaborations. So these are I think the 10 practical tips to enhance co-facilitation in co-design, and subsequently enhance the co-design process itself to create equitable opportunities for participation of CALD group people from CALD backgrounds in the co-design. So I would like to thank the wonderful team, the Can Engage project team, who are listed here for their contributions and towards my learning. And any questions? I'll stop share now.
Please join me in thanking Ash for a wonderful presentation.
Thank you. Sorry, 45 minutes.
That's all right. Are there any questions from the group? We didn't have any come in the chat. I think everyone was listening intently rather than typing questions. Please feel free to unmute and ask a question directly.
Hi, I've got one. That's okay. Thanks so much. I really enjoyed that presentation. I was just wondering, you had 4 indicators of in the medical records for identifying your people who might be culturally and linguistically diverse. In hindsight, do you think all those 4 measures are useful if you were going to do that study again? Or would you prefer some other than others?
So we use these 4 because these 4 indicators are kind of core indicators supported by the Australian Bureau of Statistics in relation to culturally and linguistically diverse data collection. But we are conducting another study at the moment, and I'm doing medical record review very similar to this. And we have expanded on this from four this. So we have included religion as another indicator. We have also included, if available, and which is very hard to find and it's not available, parents' country of birth, and also refugee status. So if there is any refugee status related data available. But from my experience so far, like as I said, language spoken at home is not routinely collected as administrative data. So when we open up Sana, it's always preferred language, which comes up, and country of birth, obviously. Religion is, I have observed now, is routinely recorded. So it's something that can be added to that in terms of identifying the cultural and cultural diversity, especially not language, but cultural diversity. Yeah.
So that makes me think those 4 indicators you're wondering aren't sensitive enough. Do you feel like you missed people? Is that
Definitely, yeah. So when
Yeah.
as I said, like because language spoken at home is not collected, that particular group of people who speak language other than English at home, but for medical reasons or communications, they speak language English, they are not recorded as CALD. So yeah, especially like I'm from CALD background, but looking at all these indicators, except for my country of birth, if that was not available, I would not be classified as CALD. So
it wouldn't be picked up.
yeah, so it's interesting in that way, yes.
Yeah, great. Thank you. Terrific.
Same here. Yes, Rahan.
Great question, Robin. We had another really good question come in. What parts of the co-design process do you wish you might have allocated more time to, if any?
I don't know. It's a very hard question to answer. So I'm involved. I'm doing co-design, another co-design now, and there is a lot of work which goes into doing the workshop, preparing for workshops before, like when as compared to when the workshop happens. So I think building relationship and the groundwork needed before doing the first workshop is very, very important in terms of identifying participants. So there are a few things to consider when we do co-design. So we have clinicians, so we have health consumers, we also have clinicians who are providing the care, but we also need to include decision makers from the health service perspective, who will ultimately be deciding or deciding on if this implementation or whatever we plan will be adopted by the health service or not. So there is lots of preparatory work needed in that respect as well. And especially when we talk about the processes in place at a health service level, there needs to be involvement apart from clinicians, somebody who sits a little bit at that process level to understand that process from a health service perspective to say what adaptations will be needed in that process. So preparation or preparatory work is something that I think there is a lot of time needs to be needed and allocated to when we are doing the co-design. Yeah. I hope that answers your question, Monica.
Looks like it did. Well done. Any other questions?
Hello, Ashrak. Amazing presentation and very interesting results. The work that you have done. I have one question, like more than a question, it would be some insights that would be great from you. So we are currently looking at planning to do a study to look at the awareness of skin cancer in people of color, and also their perception of skin cancer screening and their uptake of imaging facilities. So we assume that their perception of modesty would have an effect on their uptake of imaging. So do you have any insights from your study so far, like how we can incorporate this in our questionnaires so that we can collect meaningful information from them?
Thank you for the great question. I actually do not have any particular tips in relation to the specific uh but maybe it may be more useful to take this questionnaire to the people and ask how they would like it to be seen, or what are, so if you like, I'm completely, this is the sorry Dilka, it's not my I'm just trying to understand, like, it's definitely not my field of expertise, but I would probably go to the consumers and ask them how they would like to be involved. If they see this survey, what do they think about it, and what do they like, how they would like to be seen in that regard, perhaps. Yeah. Sorry, I'm not of much help there.
No, thank you. I understand it's from a different, very different background. Yeah, thank you, Ashwin.
Sorry, but thank you. Yes.
Any other thoughts or questions from the crowd? Robin, question 2.
I've got one more. I didn't want to hog the floor, but I will if no one else is going to. Were you surprised that you didn't get a significant relationship between CALD in the medical notes and safety events? You know, I think you said it was the approaching significance or trending towards it, but wasn't a significant relationship.
So it was approaching significance, and I wasn't I was surprised in the fact that there was not many safety events when interpreter was not. So there were two things over here. So the interpreter, so there is administrative data which says interpreter not required, right?
Yeah.
Then the actual interpreter use varied. So we did observe that when the administrative data which said interpreter not required, but when we went back and we were doing the review of the notes, there were notes which says daughter interpreted or son interpreted, or so that particular field in itself is not indicative of whether interpreter was required or not.
Or actually was provided, yeah.
Yeah, so or was provided or not as well. I did came across through a study by I think I can't remember the name, but it was Calon and colleagues, and they did a comparative analysis through the medical, I think it was medical record review study as well, and they did identify that interpreter use was not the same as when the interpreter required status. So there were differences in between the two, and we did observe in our medical record. But because we only collected administrative data, which was there in that form, we analyzed to that data, yes.
Okay, great. That's really helpful. Thank you. Great.
Very hard to say, Kinan, if they refused an interpreter or family refused, because again, being a retrospective medical record review study, you don't get that information from the medical record itself. But we did see in our interview data that oftentimes people, consumers, refused to use interpreter because the interpreters were not available the very first time, or they felt the interpreter, especially in the tight-knit small community, they didn't wanted the diagnosis of cancer to be relieved to be revealed to the wider community. So those things did impact the interpreter use through the interview data, but we can't certainly say that from the medical record review because it was very hard to say. Yeah.
It's so complex, isn't it?
Yeah, it is. It is very complex, especially when it comes to the other things. So, yeah, what we found as well, that when the interpreters were used, they were used for more formal tasks. So, for example, getting consent, because there is a policy in place that interpreters has to be used. They have to sign a form saying that person was given this information. But when we go to a very informal task, for example, if the person is going for their regular chemotherapy, they are going to the chemotherapy bay and the nurse is asking, how are you today? There is no interpreter used at that particular time because this interaction is very small, informal, may not be considered high risk. And that's the instances where there is a lack of shared understanding then. So it's like the patient is like, do I tell them that I had a constipation since last 3 days or no?
Yeah.
Yeah, those common interactions where you have that common language, like, oh, how are you doing? Oh, yeah, I'm doing well, but yeah, do you know what? Since last 2 days, I've been feeling this. That's lost.
Yes.
Yeah,
Yeah.
yeah,
Great.
yeah.
Fantastic. Thank you.
Thank you very much, Ash, for sharing your award-winning research.
Thank you. Thank you for having
Thank
me. I
you.
really appreciate it.
Yes, please, let's thank Ash once more for his presentation and sharing this information. Really valuable thinking and useful space.
Can I just have one more request from the members here? So I have another study that we are doing survey about improving consumer engagement in enhancing participation of CALD consumers in consumer engagement activities related to cancer care. I will be happy. I'm not sure if there is a mechanism through which I can distribute the survey link. It's a Delphi study. It's the second and last round. I have it posted on LinkedIn. So if you would like to go, just go to my LinkedIn page and then click on that. I will very much appreciate you completing the survey. My last request. Thank you so much.
Sneaky Ash. Thank you. Thank you so much. Thank you, everyone. Please
Thank you.
watch your
Bye.
inboxes for our next webinar in August. Cheers, everyone. Happy day.
Thank
Bye.
you. Bye.